So before I start my presentation, I must say that 90% of the work that we do is diagnostics. The other 10% is what we call translational research. It's not pure research, but it's translational research applied into a clinical context. So, and we in our department, we have a running joke with our medical pathologists. We say, we're going to find a way to retire all of you. And this was a perfect opportunity to try that, was look at these Her-2 cases and see what we get from the data. So let's move forward. So this is our research goal. What do you want to do with this digital PCR project? So basically, we want to see, we're already testing for Her-2 in our department. We want to see how comparable it is to our current testing methodology. I really like this wheel from the CDC. It was done in 2003, and it covers a lot of parameters. The three main ones are analytical validity, clinical validity, and clinical utility. I'm not going to cover all those. I'm just going to cover three things. Are we really measuring gene amplification, copy number variation, which is number one, analytical validity? When are things positive or negative, which is the clinical validity? And the clinical utility is concentrated a little bit on the financial aspect. And I don't think we can, even in research or diagnostics, we cannot neglect that aspect, which is the financial aspect. So let's move forward. So for those that don't know what Her-2 is, this is a really nice slide that in a visual way explains what Her-2 is. So Her-2 is a driver for cellular proliferation in cancer. And you can look at the proteins there. And Her-2 has several dimerization partners. There's Her-2 with Her-2, Her-2 with Her-3, Her-2 with Her-1, which is EGFR, and this is what it does. So we all have seen these pictures. We all know what they mean. And again, Her-2 gene is coded by the Her-2 gene. We don't call it Her-2 because molecular biologists always like to complicate things, but we call it Her-2. Now, the interesting thing is that the Her-2 is a proto-oncogene. By itself, it's not an oncogene. It won't give you cancer. But under certain circumstances, it will drive cancer forward. And what does it need to happen? Let me just move forward and explain a little bit more about what a proto-oncogene is. So a proto-oncogene turns into an oncogene by three different mechanisms. We have deletion or point mutation. In the previous example, looking at BRAF, was a point mutation, and that creates an hyperactive protein. That's one of the mechanisms, BRAF becoming an oncogene. The other one is gene amplification. We see that in Her-2 as well, where you have several copies of the gene introduced into the genome, and then the normal protein is overexpressed. And the other common one as well is chromosome rearrangements. We see that in translocations and a lot of other things. So these are the three main mechanisms from proto-oncogene to oncogene. And why do we test for Her-2? We test for Her-2 for mainly two reasons. The first one, we want to know if we can give that drug to that patient. So it's drug eligibility. The second one is Her-2 is a negative prognostic factor. If you look at this picture, actually, quite like this picture. So in this particular case here, the tumor spread to the nodes, and if that tumor is Her-2 positive, in this case, more than 3 copies, and you can see that 36 months after 3 years, chance of disease-free survival is below 60%. If it hasn't spread, then it's above 60%. So you can see as well that there's a difference between having an increased number of copies of Her-2 and having a normal number of copies of Her-2. So you can see the difference here. Less than 3 copies, normal, there's a higher chance of disease-free survival. This is why we test for Her-2. Let's look at the drug, see if we can give the drug to the patient, and let's see what are the chances of disease-free survival. Moving on. And how do we test for Her-2? That currently indicate there are 2 recommended methodologies. One of them is in situ hybridization. And there are 2 ways of doing in situ hybridization. The gold standard is FISH, fluorescent in situ hybridization. And what we're seeing here is in red, you're seeing you see in the gene basically, and you see in the copies of the gene. So there's a lot of copies there, and that's the reference, which is the chromosome 17. What we do after that, we count the number of dots, red dots, count the number of green dots, and then we do a ratio between the red and the green dots, and that gives us a number. And according to that ratio, we call it either positive or negative, and sometimes equivocal. Exactly the same thing with the dual cis, silver, and you can also have a chromogenic as well. So this is looking at the gene now. The other thing we can do as well is look at the protein. And when we look at the protein, we're going to look at membrane staining. So, and there's after you look at the slides, there's 4 different options for scoring these. So either 0, there's nothing there in the membrane, a little bit of staining 1, a little bit more staining 2+, and 3+. You have a continuous membrane staining. It's very, very strong staining. So this one here we call it positive, this 2 we call it negative, and that one we call it equivocal. And what we do after that, or what do hospitals normally do? So there's 2 ways of addressing Her-2 testing. The first one, you can go in and use frontline immunohistochemistry. And if it's 0, 1+, you call it negative for Her-2, 3+ positive. If it falls into the 2+ region, we call it equivocal. And after being equivocal, you can repeat the testing, or you can go and use another technique to try and see if you can understand what's going on here. This is frontline immunohistochemistry. Or you can go and do frontline inside hybridization. And if your ratio, if you remember the Her-2 C17 ratio, chromosome 17 ratio, if it's below 1.8, you call it negative. Below 2.2, you call it positive. And between 1.8 and 2.2, equivocal. And you can either repeat it or go back to IHC. Different hospitals do different things, and we work with the three other hospitals, and one of the hospitals prefers to do frontline IHC because it's less expensive. Our hospital does frontline-ish, which is slightly, well, it's more expensive, but we feel more confident with that result. This is all up for debate among pathologists and different molecular biologists. So let's move on to the other side. So this is just an overview of what happens when you call things positive, equivocal, and negative. In digital PCR terms, we don't know when we're going to call it positive or negative because we've never done this work before. So this is the main aim of the project. Yes. Right, this is our Her-2 story, and before 2007, we're sending all our samples away to be fished, and there was an issue with turnaround times longer than what our clinicians wanted, and it was also a very expensive technique. So we decided let's bring this technique in house. Let's do ISH, not FISH because we didn't have the appropriate technology, but let's do ISH, either KISH or SISH. We started with KISH. And then the technology moved on, and then we moved to an automated system, SISH. That enabled us to have lower costs and have a high turnaround time. So at the moment, where it stands with digital PCR, we like to move it forward because it's still expensive doing ISH, and we have a repeat rate that when we started doing the testing was roughly 20%. Because as you know, if you work with paraffin samples, there's a variability in fixation times, and the sample takes longer to get to the lab. There's loads of things that are not under our control. So there's a lot of variability there, and that's why our repeat rate was high as well. But now we improved a little bit. Now it's roughly 10%. But it's only research at the moment, digital PCR, and there's no guidelines available for testing Her-2 with digital PCR. Let's move on to the other side. So why do we want to test by digital PCR? There's Parker talks about the technical improvements and all the different things that we can achieve. And there's also the cost implications. And I'm going to cover that in the last slide, what it means for us as a laboratory to test by digital PCR. So there's 4 things that Parker covered: 2, competitive dynamics and post-on distribution, and the technical improvements. And there's other 2 there as well that once you start doing digital PCR, things start to get a little bit less subjective because you don't have a human being looking at a slide. You have a machine that looks at 20,000 data points, basically. I'm not saying that the people that are looking at sites are not competent, but there's a lot of, with increasing workloads, we need to find ways of releasing these people to do jobs that are more high value. And the other thing as well that I've covered is sample variabilities. Fixation time is one of them. Then we get going to the costs, staff time, reagent costs, repeat rates, and overall possible cost savings. These are the reasons why we would like to move on and do this. So this is what we started with. Actually, there were 49 samples, not 48. One of them we were a bit naughty and sent the water to Trish and to see what they would come up with, just to stretch the technology a little bit. And that came out as nothing zero, so all good there. So a good starting point. And then we had those breast cores there, and we have excision. So 20 core biopsies, 28 excisions, and then it was extracted. And then you can also see there's a huge range there from 2 to 765 nanograms in these samples. The other thing as well, we went back to 2010 and we tested 30 blocks. In my mind, if you can work with the FFPEs, you can work with everything. It's, from personal experience, a lot easier to work with the live or fresh tissue and work with blood than it is to work with FFPEs. If you can stretch it to FFPEs, then you show that the technology you have in your hands is very good. So let's move on. This is the targets that we picked. So we picked Her-2 targets because we are assessing Her-2, and you can see that those are the exons, chromosome 17, and it's following an intron really nicely. And this is the RNA-SP target. It's following an exon. We don't know what that means. We're going to look at the data. And the reason why we went with these assays, in-house assays, because we didn't want to introduce another variability in our research. We didn't want to come in and dilute primers and probes. Everything is already on the website. You just order everything and it's done. And this is what I call easy workflow. We just send the samples, and then the samples come back to us. And it doesn't get any easier than this in science. What do you get back from them? This is the raw data. This is what we get back. And what we do with this raw data that comes out of the instrument. So this is the first thing we've done is got two axes there. You got a ratio on your y-axis. You got sample numbers on your x-axis. So this is you can see already there very positive samples there, a lot of negatives, and the sample. And this is the equivocal range because we want to understand how many samples were equivocal. Because calling negatives and positives is not difficult. Difficult is dealing with the equivocal range. That's what it creates a concern in a clinical setting. Right. So the second step was ordering in a ratio, or it's a ratio order. So what I have to do there was put a log scale because I couldn't fit everything properly and look at the areas properly just by doing a normal linear scale. So, and this is where you get an increasing ratio, and then if you apply the equivocal range to it, there's maybe 3 samples that fall in the equivocal range. Let's move on. So this is the data that they've got. I'm going to spend a few minutes to explain this. So you have your sample identifier on top, and then you have your ratio there by digital PCR, and this is our result for our patient. This is what we're comparing our data against. These are our patient reports. So the reason why this is in red is because if you use the same algorithm that you use for SISH, then we're going to call this positive above the red line. Below the green line, we're going to call all those negatives. And there in between, in yellow, we're going to call them equivocal. And I think this just creates a really nice way of visually comparing our data. And we can see already that there's a couple of problems there. The first one, you can see that these are not actually matching. So we're calling these negatives, but if you use the each ratio, and they're actually positive, there's a problem there, which might mean that our interval for digital PCR needs to be moved to the left. The second one is that you got 2 naughty samples there. There's a negative one that's coming up in the positive range, and you got a positive sample that's coming in the negative range. So these were the samples they went in and investigated further. So with their first sample there, sample number 34, and their sample 22, Sample 34 went back, we checked the samples, we checked the size, we checked the results again to make sure that we didn't have any problems transcribing the data. And then we asked Trish to repeat with another, or Trish repeated with another gene, APP. And actually, if you use another reference gene, the ratios, that sample 34 moves there. It lowers the ratio. So it might have been a problem with RNA-SP, and there's something to consider. Which reference gene are you going to use? The second sample is a bit more tricky because we call this positive, and it's falling within the range. We tried exactly the same things that we did for the data here, and it still came out as negative. So what we had to do then, we went back to the original block, we recut the sides, retested everything, and it actually happened that we were wrong. This result was actually negative. So there was a problem there, and we had to sort this problem out. So that patient was given a wrong result. We actually picked it up for digital PCR. So, now moving forward, this is how our data looks like if it's reorganized. And you can see as well the equivocal range there. And what we're going to do is we want to enlarge the equivocal range. So we kept the equivocal range for a reason. We could have we could have slided down to this area here and call this area equivocal, but we kept that one because we want to take this further. We wanted to make this part of recommended methodologies portfolio. Currently, there are only 2, ISH and IHC. We'd like to see digital PCR as part of a recommended methodology for Her-2. So moving forward, we'll keep this interval here, and we lowered it a little bit as well. So we have a nice, we're going to call that equivocal. We want to do that because we want to make sure that patients in this area are properly examined and seen if they are truly amplified or not. So let's move forward. So we have a lot of positives here, a lot of negatives, and we enlarged our equivocal range. And what does this mean in terms of workload for the lab? So 12 samples fall now in the equivocal range, 14 samples in the positive range, and 22 samples in negative range. If you were running this diagnostic, and I know that this is a research project, but if we were moving this forward, these samples here, positives and negatives, we don't need to test them. Only these ones to reflect to ISH or to IHC, which would be 25%. So we could decrease potentially the workload down by 75%. So you'd spend a lot less on reagents. Let's move on to the other side. So this is a working algorithm. A couple of things we need to fix. Maybe use another reference gene other than the RNA-SP. This would be our algorithm. Anything that's below 1 we call it negative, anything above 2.2 positive, and then we reflect that to IHC or ISH. And what does this mean for us in a lab setting? So try to understand the beginning. Are we really measuring copy number variation with digital PCR? And we can say that yes, but it depends on the reference gene that you're going to be using. So you have to be very, very careful choosing your reference gene. This is something we didn't know before starting this project. We thought that all reference genes were alike, but they're not. Secondly, because of the ratio, this seems to be a lot more sensitive than what we're currently doing in the lab using the current ratio of 1.8 to 0.2. So that's something that we need to consider as well. And this falls within the clinical validity. Above a certain value, we call it positive. Below a certain value, we call it negative. If you have that very, very well tightly controlled, then it's very easy to do this. The third one is cost savings. We talk about cost savings a lot, money, which is the dirty word. But for us, this 75%, if you reflect back to, if you do digital PCR, 75% of our samples, for us, we run 1,500 samples a year. We manage to save £100,000 a year. Which is not, it's a significant, it's not an insignificant amount. And what does that mean to us as scientists is that money can go in to buy 2 sequencers, for example. And this is the long term. It's just not about money, but it's moving the science forward and using the tools that we have available to move the science forward. And so far, so good. And taking any questions now.